Made of 3 bones: humerus, radius, and ulna.
Yep.
So let's leave it down. Humerus, radius, and ulna. Which one's the humerus? Yes, the upper body. Ulna and radius. Why is it called radius? Because it rotates. The bone actually rotates when you move it. So if you break your ulna, all right, which is on the pinky side, if you were to have a fracture on your ulna, you're just in a cast from here to here because it doesn't rotate. If you break your radius, you must cast from your metacarpal carpal joint all the way past the elbow and up on the humerus to keep you from rotating your hand back and forth. Otherwise, it's going to stay fractured. Here we go. See, if you have an ulnar fracture, where's homie? Okay, he probably has an ulnar fracture. It just goes and covers the part that's broken. If he had a radius fracture, he would go from here all the way to here to keep him from pronating and supinating. All right, your ligaments are your ulnar collateral, your radial collateral, and your annular ligament. The ulnar collateral and radial collateral tell you exactly what they're doing or what side they're on. They hold that to the humerus. So think of it as your MCL and your LCL of your knee, but at your elbow. Okay? And then you have to have something to hold the ulna and the radial and the radius together, so that's your annular. Elbow is considered to be a complex joint because of the humerus touching the radius and the ulna. You've got 3 bones coming together. Flexion and extension of the forearm are carried out through the sagittal plane, and supination and pronation through the transverse plane. Probably the #1 injury, contusions. Oh, I bet you guys, I don't think they've seen a dislocation here in their history.
Yeah, it was there.
Could be.
There, yeah, it was located.
So you can see, it takes 4 years to see one. And I've only seen, we had that one, I think I've seen 3. So, because of lack of padding, the elbow is vulnerable to being contused. The contusion of the elbow may swell rapidly after the initiation of the olecranon bursa. All right, so you have bursas. We've talked about bursas before. They're those little sacs that have the synovial fluid. You hit it, and boom, it swells all the way up. So they're pretty susceptible to getting hurt, especially when you're getting tackled on that hard turf, and bam, it hits right there. We had one guy in school that he had that golf ball, looks like a golf ball, hanging out right there. And so we waited for the doctor to come in after practice to suck all that fluid out. Well, if you're going to do that, don't ice it, because then it turns into like jello, really thick jello. All right, so you treat immediately with ice and pressure for at least 24 hours, and then of course, on for 20 minutes, off for an hour. If the injury is severe, the athlete should be referred to a physician to determine whether or not they have a fracture. Olecranon bursitis. All right, let's see if we've got here. Here's your olecranon, and it fits on the humerus and the olecranon fossa. So a fossa is like a little spooned out area. And so we look here, here's the olecranon, and it fits into the olecranon fossa. So that keeps you at stopping at hopefully 0 degrees. Some folks get negative degrees. You've seen those people where their elbows come up and back? Sometimes they have that. So you view that olecranon sitting right here. If it gets hit, that bursa gets hit, it gets really swollen. So olecranon bursa, the line between the end of the olecranon process and the skin is the most frequently injured bursa in the elbow. It becomes inflamed, it produces pain, severe swelling with point tenderness, and you treat with a cold compress for at least an hour, aspiration to hasten the healing with the persistent swelling. If you're going to do that, do not ice it before you do the aspiration or the sucking out of the fluid. And wear a compression sleeve. That compression sleeve sitting there is just like a sock, but it's tight. And so it will help push it and widen that bursa, and that swelling then gets absorbed. Strain can occur to the biceps tendon, the triceps tendon, and the brachiallis muscles. These muscles should be tested through active and passive range of motions. All right, I'm about seeing where the biceps are there. You feel it right there on yourself. If you just take your arm, you bring it up, you can feel right here, there's a tendon. All right? You push back this way, you'll have a tendon on each side on the back of it. That's your triceps, that's your biceps. Where can you see this? Pretty much anything as far as football for sure. You can see strains in pitchers, baseball players. They're starting baseball this week. They go out there and they start throwing. They think that they can throw with a full range of motion at full speed. And the next thing you know, those muscles are saying, whoa, dude, what is this? You let me chill out for 4 months, and now all of a sudden you want me to go full speed. They get strained. Football gets strained. You go up for a tackle. As you go for the tackle to somebody, he's running to you. You're running to them. You're trying to flex your elbow. And as you're compressing, it gets pushed out. That's going to strain your bicep tendon. The signs include tenderness during active and resistive range of motion, and point tenderness on the muscle tendon or lower part of the muscle belly. So you can treat it with price. Wear a sling if you have to. Let it settle down. And just because they have a sling doesn't mean that they're going to miss that ball game. That means you're just going to let it settle down until you get it better. Follow up with ice, ultrasound, rehab exercises. If you need to, x-ray to rule out a fracture. So if you grab your partner and do-si-do, all right, pull this to you, and that person should be able to help her find your biceps tendon. So you can find your biceps tendon. Oh, wake up, pull. Pull. Feel the biceps tendon. Sure, Sarah. You can feel that string that gets taut. Right there.
Oh, this one.
Yeah. The other was the brachiallis muscles that are attached then to the humerus from this side. So what that's telling you is that I'm going to take that and I'm going to say pull. And she does, and then I push on that tendon. If that tendon hurts, then certainly she can also do it herself. Go, okay, or with resistance. Prende? Don't need that one. Sprain, usually caused by hyperextension or valgus force. Okay, hyperextension certainly causes that ligament down here to get sprained. The pain, you have pain in inability to throw or grasp, point tenderness over the medial collateral or the ulnar collateral because the ulna is on your pinky side. So that comes up right to here. Now think of that as if it was a leg. If you got hit on the lateral side, boom. If you hyperextend it, which is what's going to cause this one. I'm going for a tackle and somebody else is tackling the guy at the same time, and I've got it out, and my other guy comes in and hits it like so, it's going to hurt. So we're going to do a valgus stress test on it. And we do a valgus stress test, and it's going to find out whether or not it is going to be an MCL sprain. Now, to do that valgus stress test, may I borrow? All right? You do it just like it was a knee. Now, what's the other thing that's going to be? So that MCL is right here. What also is right there? No.
Ow.
Right there?
Oh, I do that to people all the time. I try to.
So you got nerve tissue that's right there. So if you stretch your medial collateral, you can actually end up stretching that ulnar nerve. Now, knowing where that nerve goes, if you find out that they have tingling in these two fingers, it usually goes from the middle of your hand over, all right, is the sensation. So if those show up tingling, now you very well may have some nerve problems going on. You stretch it along with your MCL. So now you've got to worry about it. When you're icing, not cupcakes, but when you're putting ice on an MCL injury, make sure you tell the people. I tell them do not do it 20 minutes. That's too long for it being that close to that nerve. I tell them no more than 15 minutes. I also tell them if it starts to burn, feels like a nerve burn, take it off immediately. As you can do, using ice can damage those nerves to where it's over. They're done. They don't get to use those fingers anymore. A little bit of ice is better, so a whole lot of ice is, even more is even greater. That's not true. So treat with cold and pressure, 24 hours with a sling support at 45 degrees flexion here. Control your hemorrhage, and then you can start using heat, massage, range of motion exercises. I would also start using laser. I would use ultrasound. And, of course, you need to tape and brace when they're ready to return. When you're taping them or bracing them, you need to get them probably close to 90 degrees. We don't want them at full extension, but the reason why we do them here as opposed to where we want it to actually stop is when they're going to start to play. All of that's going to give. So exaggerate how far you want it to be limited, and as they play, it will eventually get out there. But at the end of the game, you still don't want them at 0 degrees. So most of your athletes will complain saying, "Oh, well, that's awful. I don't like doing it that way." Well, you're going to have to suck it up. So tomorrow, what we're going to do is we are going to tape elbows. We're going to tape elbows since there's 6 of you. So that means one of you will do one tomorrow. If we got time, then the other one will do it. If not, we'll do it the next day. Well, she can do sling. His right elbow. We'll have him. So tomorrow we're going to tape elbows. So we're going to tape elbows. How? We'll show you tomorrow. We use a whole bunch of different tape. We don't use a lot of white tape. We use actually the elastoplast or elasticon, the brown stuff. Very good. We'll also show you some of the braces that we have in there. So here he is doing testing of the elbow. So lateral epicondylitis. Anybody ever hear of this? Nobody's ever heard of lateral epicondylitis? Has anybody ever heard of tennis elbow? Oh, I think I have tennis elbow. That's what it is. It's just tennis elbow from repetitive motion over and over and over. And it hurts. Bend your arm. It hurts right there. And it hurts pretty good. Feels like there's a little leprechaun in there with like a scalpel that just stabs you over and over and over. Chronic condition that may affect athletes who execute repetitive or repeated forearm flexion and extension movements, such as the backhand in tennis. This arm, if I'm playing golf, all right, pitching, throwing curveballs, okay. So it's usually microtrauma on top of it, on top of it, on top of it. When I worked in a clinic one time, this lady came in and she had lateral epicondylitis. I said, how do you get that? And she says, I pick something up every day. My job. I pick it up, put it on a hook, up on a hook. Not that it was super heavy, but it was just heavy enough to where she had to constantly use submaximal threshold. And if you do this for 8 hours a day, surprise, she didn't have bicep tendonitis also up in her shoulder, but she had lateral epicondylitis. So, most often seen tennis backhand caused by repetitive microtraumas to the insertion of the extensor muscle of the lateral epicondyle. Meaning, here, you can feel it up here, so constantly. So if you just take your hand and go here and come all the way to the top, you'll feel that muscle to where it finally gets larger. Pain is that it's gradual and becomes worse, but it can be debilitating. It can be ouch. So that same place when I was working there, I was working and we were doing football, of course, but we didn't have a situation to where we had a field house. We actually were in a warehouse. And then we had to drive 15 miles to go to some school and practice at the school, and then come back to the warehouse and unload there. So everything's in trunks. And so every day we're picking up these trunks, putting them in the truck, picking up trunks. And I ended up with tennis elbow too. It's not fun. How are you going to get rid of it? Well, include rice, non-steroidal anti-inflammatories, and you treat with range of motion exercises, progressive resistance exercises, deep friction massage, where you take your thumb and you just go back and forth over that. It hurts them super bad, but they will feel the influx of blood coming to it. You actually got to be careful if you're being the treater of the patient, because you can end up to where now you get tendonitis in your thumb. So now you've treated them to health, but you've ruined yours. Not really ruined it badly, but hand grasping and supination. All right, that's why the hammer's here, the actual, hammer. We'll put it on here like that. And you're going to avoid pronation movements. You can wear a neoprene sleeve for 1 to 3 months. And you see tennis players or whatnot when they come in and they have like neoprene sleeves, looks like a CHOPAT for your patellar tendonitis, but you put it up here. Ultrasound is great if you incorporate hydrocortisone cream, where you use phonophoresis and you push the cortisone through there. It is absolutely super for epicondylitis. I believe lasers would absolutely help it also. So medial epicondylitis. Now we're on the opposite side. Pitcher's elbow, like lateral epicondylitis, but it's on the other side, on the medial side. Pain over the medial epicondyle of the humerus, that can be produced during forceful wrist flexion and extension. All right? Treat with rest, cryotherapy, and heat. Through the application of an ultrasound, anti-inflammatory drugs would be great. I don't even know what this is. It's some kind of brace applied. I'm sure it's the same kind of brace. Thanks for TAs. All right, dislocation. Super cool. What time are you guys done? 49? There's a dislocation. Saw one about 3 weeks ago. I worked a wrestling match. It was the girl. Yes, girls wrestle. The girl got caught this way, and whoop, out it came. Her mom said, well, if it was a shoulder, I could have popped it back in. The athletic trainer that was there actually did reduce this dislocated elbows. I don't particularly care to mess with them because remember that over here, and you touch right there, and there's nerve supply. You've got two sides of arterial supply. You there's too much vascular and neurological pathways going through there. That if I get something trapped, and then it's me, it's on me. Check, make sure they have a pulse, make sure they feel, make sure there's capillary refill in their fingers. If they've got a pulse, leave them. Don't walk away. I'm just saying, leave them, dislocate it, put it in a splint, and send them on their way. Caused most often by either a fall on an outstretched arm with the elbow in a position of hyperextension or by a severe twist while it is in a flex position. So the involved rupturing and tearing of most of the stabilizing ligamentous tissues accompanied by profuse hemorrhage and swelling. So meanwhile, you've got two bones being held together by their muscular attachments as opposed to ligamentous attachments. Not fun. Severe pain and disability. Nerve and blood supplies may be disrupted. So if you see this, obviously you're saying, whoa, that's what's wrong. Check a pulse. Get a SAM splint, bring it around the back, take another, and come across here and hold it like so. So don't mess with trying to reduce those. All right, we're almost there. Elbows to injuries. Remember to treat by applying cold and pressure immediately in a sling, and to refer the athlete to a physician for reduction. This is talking about the dislocation. Never reduce a dislocated elbows. Always allow a physician to do this. Check for a pulse. Watch for capillary refill. Ask them if they can feel you scratching their hand. It must be reduced as soon as possible. And once your healing has occurred, use heat, passive range of motion. Strenuous exercise should be avoided until instructed by your physician. That is when you start seeing those people that are playing football and like they got the J.J. Watt elbow brace. Well, he probably dislocated his elbow, but he did it years ago. So he feels so much more comfortable with it, he's been wearing it ever since. That brace is about $1,000. So it's not the brace that we have to get when we see somebody's got a hyperextension. That one there is like $100. Big difference. But they essentially can do the same. They're just not as low profile. Questions? Tomorrow we'll tape. Next day is today's Tuesday.